On behalf of the Chicagoland Clinical and Translational Science Award Hubs, I would like to welcome you all to our discussion, Breaking Barriers, celebrating 30 years of the NIH Revitalization Act in women's health research. My name is Nikki Wojtowicz, and I'm the Executive Director of the Northwestern University Clinical and Translational Sciences Institute within the Feinberg School of Medicine. I'm joined today by several of my colleagues, Dr. Shika Jain, Vinny Arora, Janice Phillips, and Annabelle Volkman. We look forward to spending the next hour with you discussing the role of the pivotal 1993 NIH Revitalization Act and its impact it's had on women's health over the past 3 decades. To get us started, Representative Jan Schakowsky from the Illinois 9th Congressional District would like to share a few remarks.
Hi, I'm Congresswoman Jan Schakowsky. I represent the 9th Congressional District of Illinois. I want to thank Dr. Nicole Wojtowicz for inviting me to say a few words of thanks today. And I am just thrilled to join with you to celebrate the 30th anniversary of the NIH revitalization legislation that has so much to do with making sure that women's health is being investigated. And I know for years, women have been underrepresented, particularly women of color, when it comes to research on healthcare. But thanks to the passage of the Revitalization Act, now 50% of the participants in research are women. And I am particularly proud of the research that is being done in our own community looking at women. There's been a particular focus on diagnostics for breast cancer and also work being done on ovarian cancer as well. So congratulations to the doctors and researchers at Northwestern University, at the University of Chicago, and the University of Illinois in Chicago.
And Rush University. We appreciate and Loyola University. All of the affiliated institutions with ITM. We appreciate the Congresswoman's remarks and her continued advocacy for women's health. To set the stage, I'd like to take a look back in history at what got us here to this place and this time today. So some of you may be familiar with this history, but just so that we're all on the same page starting this conversation, let's review a little bit. In 1977, the Food and Drug Administration released guidance that women of childbearing potential were to be excluded from Phase 1 and Phase 2 clinical trials. This was at the time in response to the thalidomide tragedies of the late 1950s and early 60s, which luckily did not make it to the United States market due to the efforts of Dr. Frances Kelsey. All right. Along with several other drugs that were discovered to have severe birth defects. So despite being well-intentioned to prevent harm, this policy actually had unintended significant consequences. So to that end, in 1985, a report by the U.S. Public Health Service stated that the exclusion of women was detrimental, recommending that biomedical and behavioral research should be expanded to ensure emphasis on conditions and diseases unique to or more prevalent in women in all age groups. Followed up by that in 1990, a GAO report found that the NIH had made little progress in implementing a policy to encourage the inclusion of women in research study populations, and that the policy, quote, had not been well communicated or understood within the NIH or in the research community. And later that year, in response to that feedback from the GAO, the NIH established the Office of Research on Women's Health under the directorship of Dr. Vivian Pinn, with the charge of ensuring that women's health is appropriately represented in NIH-funded research. So then in 1993, the Revitalization Act was signed into law, requiring that women be included in clinical research to, quote, ensure that trials are designed and carried out in a manner to provide for valid analysis whether the variables being studied in the trials affect women or members of underrepresented minorities. It also codified into law the existence of the Office of Women's Health Research at the NIH. So that's what leads us to today. And I really was hoping that we could set the stage and look forward 30 years later. So we've come together to discuss this afternoon the advances that have been made and recognize that the profound impact that this policy has had on women's health, advancing medical knowledge, and fostering inclusivity in biomedical research. However, we're also all here today because we recognize that there is more work to be done, and I look forward to hearing the thoughts of our panelists as we talk about the future landscape of women's health. So today, I would like to start by introducing our terrific panelists. So please just give me a moment in welcoming them. So first, I'd like to welcome Dr. Janice Phillips, who is joining us virtually this afternoon. She is the Assistant Director of the Illinois Department of Public Health. She is a results-oriented health professional with experience as a clinician, researcher, educator, nurse regulator, author, and public policy advocate. She most recently served as the Director of Nursing Research and Health Equity at Rush University Medical Center and Associate Professor in the Department of Community Systems and Mental Health Nursing at Rush College of Nursing. In her new role, Dr. Phillips is focused on the elimination of health disparities and inequities through the establishment of new and strengthening existing collaborations between IDPH and external community partners across the state, including the 97 certified local health departments throughout Illinois. I'm also joined by Dr. Shikha Jain, a triple board certified hematology and oncology physician. She's a tenured associate professor of medicine in the Division of Hematology and Oncology at the University of Illinois in Chicago. She's the director of communication strategies in medicine and the associate director of oncology communication and digital innovation for the University of Illinois Cancer Center. She is the founder, CEO, and president of the nonprofit Women in Medicine, founder and chair of the Women in Medicine Summit, as well as the CEO and co-founder of the Action Advocacy Amplification Organization, Impact. She was named one of Medscape's 25 Rising Stars in Medicine in 2020, a Modern Healthcare Top 25 Emerging Leader of 2019, and was awarded the Rising Star Award by the Lead Oncology Conference in 2019. She was appointed as the 2022 lead of the American Society for Clinical Oncology Women's Networking Center Task Force. Wow, is that a mouthful? And is appointed to the Illinois State Medical Society's Council on Communications and Membership Advocacy. Welcome, Shikha. Okay, we've got several other phenomenal panelists with me today. As the Dean of Medical Education at the University of Chicago Pritzker School of Medicine, Dr. Vinnie Arora leads the strategic vision and implementation of innovative curricula and programs that prepare the next generation of physicians for the challenges and opportunities of medical care. With more than 2 decades of experience in medical education, quality improvement, and patient safety, she has a proven track record of engaging and aligning frontline health professionals and learners with the mission and goals of the health system. An accomplished researcher, Dr. Arora has served as a principal investigator of numerous federal and foundation grants. Most notably, she has developed tools to evaluate handoff quality among hospitalists and residents. Through R01 funding, Dr. Arora is studying the impact of a novel social media intervention to boost the interest of minority youth into medical research careers. Dr. Arora's work has been funded by the Agency for Healthcare Research and Quality, the National Institutes on Aging, and the American Sleep Medicine Foundation. And last but certainly not least, Dr. Annabelle Volkman is the co-founder and medical director of the Rush Heart Center for Women, the first heart program in Chicago devoted exclusively to women that opened in 2003. She is the Madeline and James McCullen Carl E. Ebel Professor of Excellence in Clinical Cardiology at Rush and a nationally recognized leader in cardiology care and research. A fellow of the American College of Cardiology and the American Heart Association, Dr. Volkman has dedicated her career to helping women and their families lead healthier lives through the prevention and treatment of heart disease in women. Dr. Volkman has written and published numerous abstracts and articles for scientific peers and mass audiences. So welcome to these phenomenal panelists and colleagues. I'm so thrilled to know them personally and then also to share, have them here to help share their expertise with you today. It's already been agreed upon by the panelists that I'll use their first name in our conversation this afternoon. So, without further ado, I would really like to welcome Dr. Janice Phillips to give some remarks, joining us virtually, and we really thank her for her participation to be willing to work with this technology this afternoon. Unfortunately, we won't be able to have a back and forth dialogue with Dr. Phillips, so we'll save some time at the end of our conversation to save some questions for her.
Hi, everyone. I'm so sorry that I can't be with you today, but I am just delighted that we are having this conversation, and what a wonderful time to celebrate this 30th year anniversary. But I got to begin by telling you how I got my start. I actually began to do my own women's health research back in 19 never mind when I went to graduate school, and I had the pleasure of having Dr. Joellen Wilbur as my academic advisor. Dr. Wilbur hired me as her research assistant, and at that time, she was already doing women's health research. But I wanted to take my love for breast cancer disparities into my dissertation work. And I remember very vividly her telling me that that's good, that's a body of work that we need to know more about. But keep in mind, Janice, that there's diversity even within your population of women. And so my dissertation looked at adherence to breast cancer screening guidelines, looking at both low and middle income African American women. But little know that of looking at women from that particular perspective would be instrumental in landing me a job at NIH. So in 1999, when I arrived at the National Institutes of Nursing Research, we were busy still rolling out the NIH Revitalization Act. And in my capacity as a program officer, I was charged with working with nurse scientists and other researchers across this entire country. And one of the key variables was looking at their work to see how well they were including minorities. And if they weren't doing a great job or needed more instruction, I was the one of many others, who would guide them about minority recruitment. So I had an earlier appreciation of what this piece of legislation meant as it relates to advancing not only just research, but nursing research and research for minority women. I went on to manage a lot of grants that focused on women's health, and one in particular was the SWAN study, the study of women across the nation. And I have to admit, I didn't realize the significance of that until a few years later, but the SWAN study was a 25-year longitudinal study, first of its kind, to examine the menopausal journey of women. It included a diversity of women. You got Japanese women, Chinese women, Black women, Hispanic women, white women, underscoring the importance of looking at diversity and looking at minority populations and realizing that one size doesn't fit all. One population's experience may be different from another. We found out from some of those preliminary findings that Black women in particular experience menopause at an earlier age to use hormonal therapy. So very important for that inclusion of women. We've had some other advances throughout the years. We've had the Black Women's Health Study funded by the National Institutes of Health, realizing the importance of including minority women and a focus on Black women. That study has generated over 300 publications. And guess what? We've learned a lot by having a specific focus on Black women. We know today, even since we've had the enactment of the Revitalization Act, we know that women, minority women, women of color, still remain underrepresented in all forms of research, and especially when it relates to clinical trials. I think that research literacy plays a very important role in trying to make sure that we have the right representation. When we think about the historical atrocities of studies like the Tuskegee study, for example, yeah, it's important to acknowledge the history. And I would like to think that our researchers who are conducting research are familiar with those atrocities and others. But I also want the public to know that we've had some advancements since those earlier days, and there's more scrutiny and more accountability in terms of protecting their rights if they choose to participate in studies. We still have a ways to go. We can celebrate today, but we certainly cannot rest on our laurels. I think about all the nurse scientists that I have encountered over the years. I think about the Nancy Fugate Woods at the University of Washington, who taught us a lot about menopausal health. I think about Joellen Wilbur, also funded by NIH, who taught us a lot about physical activity, not only just in women in general, but also minority women. And I think about Loretta Sweet Jamont, who's a minority nurse investigator, who's taught us a lot about HIV/AIDS mothers and daughters. Again, those are just a small sampling of the wonderful nurse scientists that I've been privileged to work with. And I'm very grateful that we have a National Institutes of Nursing Research at NIH that is really concerned about advancing women's health. We've supported other studies with other institutes. There's been a heavy investment in terms of trying to create a cadre of nurse scientists to continue to advance women's health research. But you know what? If I had to wrap up what I had to say, I would say that the way forward, we have to continue to care. K-A-R-E. We know that there's still a gap in what we know about women's health research for all women. We also know that there's a tremendous gap in terms of what we know about minority women. I was blessed to learn earlier that one size does not fit all. We talk about African American women, but then there's a population of Black women. So what do we know about that population? Those populations, the one size fits all does not work for us. There's a lot of diversity within each particular group. We need data from clinical trials. We need data from qualitative research, quantitative research. And I really want women to understand that there's a difference. There are different kinds of studies, but we need their participation in all kinds of studies to advance what we know about women's health. And I think advancements, I think it's important that we let the public and particularly minority populations understand the advancements that have been made, particularly when we talk about the protection of human subjects. There are still individuals today who do not trust researchers. How are we going to rebuild that trust with individuals and with communities? I say one way to do that is to make sure that there's some research literacy that goes on. And I think that the time to promote research literacy is not necessarily at the time that we want people to participate. Can we find venues and forums and platforms to advance research literacy? So in the event that we do need participation, that we want participation, people will be familiar with what we mean by research and the importance of research in terms of advancing knowledge. And then there are resources. I know today of someone who is enrolled in a clinical trial. It's a life-saving clinical trial for her. But guess what? She's in the trial, but she does not have the funds for transportation and hotel when she journeys through another city to enroll in the clinical trial that is definitely important for her and her well-being and her life expectancy. So we got to still continue to advocate to make sure that women have the resources that they need. There are issues and there are still barriers. And so what are we going to do to make sure that those resources are covered? So if they do wish to participate, that those barriers have been addressed. We also need more resources to make sure that we are infusing resources into developing the next generation of researchers with a focus on women's health research. So again, we're celebrating today, but we still have some opportunities and some work to do if we want to continue this continuum of advancements in women's health research. And then I think another key message for me is exemplars. I think that particularly for women that I work with over my career, they need to see people just like themselves as scientists, but also as participants. I personally have participated in 3 research studies, clinical trials, if you will, not because I was an unhealthy subject, but I felt I really couldn't promote research participation in my community if I didn't know what that was like. The last clinical trial that I worked in, that I participated in, was a colonoscopy study offered at the University of Chicago. And trust me, I did not participate in that to get 2 colonoscopies in one day. But I felt it was important. And guess what? I learned a lot about myself. I learned a lot about my health and my well-being and my risk factors in every single clinical trial that I participated in. And the last one, the colonoscopy trial, actually was life-saving because they found a polyp on the virtual colonoscopy, the experimental colonoscopy, versus the traditional colonoscopy. So as an exemplar, I think people need to see people that have actually participated in studies. And when I think about exemplars, I think about my dear colleague, Alicia Cook. She is a strong advocate. She's a breast cancer survivor. And when you see her out and about, she's always talking about her experience, trying to encourage other women, trying to educate other women. So people need to see people just like themselves, not only as participants, but as actual scientists. And when I think about this next generation of nurse scientists, minority nurse scientists, I'm very proud to know Dr. Monique Reed from Rush University. Young, budding nurse scientist who's looking to fill the gap in terms of looking at physical activity in African American women and their daughters. So we need to continue to generate knowledge, help people to understand that there are different levels of research, making sure that we have people understand the advancements that we've made in terms of protection of human subjects. We are collecting data in different and new ways. So how are we going to bridge that digital divide? And then what about resources for people who want to participate? What do they need so that they can engage themselves and participate in some of those life-saving trials that we are actually promoting? And then what about resources for building this next cadre of scientists who are going to advance women's health research? And let's not forget about those exemplars, the people that are out there doing the research, the people that can relate to the community. And even if there's not that cultural congruence, I think all scientists, if they're talking about the recruitment of minorities, we've got to approach it with a little bit of cultural humility, the willingness to learn and to listen and to provide the right connections for people. And then also, too, making sure that our nurse scientists, our scientists that are minorities, that they are positioned to tell their stories and serve as role models for others to pursue careers in women's health research. So thanks. And again, I want to thank you for inviting me, and I can't wait to hear our next steps. Thank you.
Janice. All right. Thank you so much, Janice. We really appreciated your perspective. And I think we already have a few good talking points that can kick off this dialogue this afternoon. And I really liked Janice's acronym of CARE with K. And I'm going to start with knowledge for it, as she so defined. So my first question to the panel, from your purview, what are some of the largest gaps in our understanding of how sex and gender influence health and disease?
Well, in cardiology, it's huge. We're finding that out. I could give you a history lesson, and I'm going to do it very briefly because I know we don't have as much time as I would like. We learned about heart disease, specifically coronary artery disease, that it was a man's disease because when we did the Framingham heart study, you follow these people as they get older, and the men were dying of heart attacks in their 40s and 50s, but the women weren't. So they thought, oh, it's a man's disease. It wasn't until much later, after they followed them, it's an observational study, that the women started dying of heart disease in their 50s and 60s and 70s. So it was a much later, but it was labeled as a man's disease. And there were studies that specifically only used men as participants in the trials. There was one trial called Mr. Fit, and there was not one woman in that trial. So it was a man's disease. And then later on, the Nurses' Health Study, which is another observational study, found that women who were given hormone replacement therapy seemed to do better in terms of cardiovascular events. And so then again, we made the mistake of thinking that hormone replacement therapy was the way to treat women to prevent heart disease. What we didn't know was that it was an age issue. If you start women with no coronary artery disease, very close to their perimenopause, within 10 years of menopause, they did better if you put them on hormone replacement therapy. But if they've already have established heart disease, remember the WHI study, which was started by Dr. Bernadine Healy when she was the first NIH director, studied all kinds of diseases in women, and she was the one who started the Women's Health Initiative, given hormone replacement therapy. Well, that study showed that when you give it to older women, they actually had more cardiovascular events, more strokes, more deaths, more heart attacks. So we took a long time to figure this all out. So it's just an example of why there is so much sex differences, especially with coronary artery disease. And then it was later on that we realized that women tend to have more microvascular disease that affected them, that made them have chest pains and positive stress tests without obstructive coronary artery disease. But it really led to terrible quality of life, mistreating women in the emergency room, being told that it's all in their head. They would get a cath and they would be told there's nothing wrong with you. You have no coronary artery disease that's obstructing your blood vessel, so there must be something wrong with you in the head. It was really a horrible period in our time. I was a fellow, and first few years of my attending years, well, we didn't know what to say to these women. We don't know why you're having chest pain. We know you have a positive stress test, but your cath was negative, so it was considered a false positive. Now we say there are no false positive stress tests. There must be something wrong. So we mistreated women for so long, for so many decades, and we still don't know a lot, but we are now starting to make some headway into treating diseases that affect women specifically, of course, menopause, pregnancy-related diseases, preeclampsia, peripartum cardiomyopathy, and then stress cardiomyopathy, which is a disease where it feels like a heart attack under severe stress, usually negative stress. Your heart would balloon out. And it's the most fascinating pathophysiology. Women who undergo severe stress feel like they're having a heart attack. They go to the emergency room. They have EKG changes. We take them to the cath lab. There's nothing wrong with their coronary arteries, but their hearts are ballooning out. And 90% of those people are women. Why that is, we still don't know. But we are starting to understand that. Another disease is heart failure with preserved ejection fraction. More women with heart failure have this disease as opposed to the heart failure with reduced ejection fraction, which usually comes as a result of heart attacks. So it's not, it's not unusual that women with a lot of comorbidities such as hypertension, diabetes, have this heart failure with preserved ejection fraction. So these differences, we're just starting to learn about them, and it took a long time to find the right medications for them. For so long, we didn't know what to do with these women. We just balanced their diuretics and hope for the best. But they lived terrible lives. So we really need to be better about sex differences in heart disease and all other diseases as well.
So I think, is this on?
Not
Can
yet.
you guys hear me? Are we on?
Yeah,
There we
now
go.
you are.
So, it's interesting, and I agree with everything Annabelle just said. If you look back historically, Nikki mentioned this earlier, but it wasn't until the post-Civil War era that women started entering into the healthcare workforce. And prior to that, any woman who presented with any symptoms was thought to be histrionic or complaining or crazy is what they would call them back then. And it wasn't until women entered the healthcare workforce that we started to see women not being seen as sickly or frail or histrionic for coming in with symptoms. Now, this was post-Civil War. Annabelle's talking about when she was in residency fellowship. That was not post-Civil War, right? That's more recent than that. And women's... well, I wasn't going to call out the number of years.
It was a long time.
But even now, women's symptoms are ignored. And a big part of that is because the studies that were done did not include women. You hear the stereotypical chest pain, elephant on my chest, pain going down into your left arm. That's what you learn in medical school about what is a heart attack. But as we just heard, that's not necessarily how women present with heart attacks. But because women were not included in these studies, women come in with symptoms and they are discounted. Anecdotally, you can read on TikTok, on Instagram, on any social media platform, hundreds of thousands of women who share times where their symptoms were ignored. And so this is one of the really big reasons why we need to make sure women are being included in clinical trials, and the data that we're using is applicable to women, not just men. If you talk about medications, so I'm going to give you an anecdotal example. For those of you who've met my husband, he's a foot taller than I am. He weighs more than I do. We will take the same exact medication at the same exact dose and react very differently. Why is that? Well, he is a foot taller than me and weighs more than I do. In our pediatric patients, we dose them medications according to their weight. Why do we look at men and women and give them the exact same dosing of medications and expect them to respond similarly? There's one medicine in particular, when we were dating, my husband would always want me to take. It's an allergy medicine. And I used to tell him, it puts me to sleep. And he's like, no, it's a non-drowsy medication. I took it and I almost crashed my car because I was so fatigued. And he takes it every day and it doesn't bother him at all. So even now in 2023, some of the medications that we're dosing are based on studies that predominantly were based on male physiology. So when you talk about the difference and why this is so important, we are doing a major disservice to 50% of our population when in 2023, the data we're using is data, observational data, retrospective data, and then actual clinical trials with actual interventions that did not include women in the studies. And we're doing a huge disservice. As an oncologist, I can't even tell you how many women come in with late-stage cancer because their symptoms were ignored because they weren't the typical symptoms that were seen on the clinical trials. And then you look back at the trials and you say, oh, there were 10% of women enrolled in this trial. Obviously, you're not presenting the way the 90% of the men did. So when we talk about why this is so important, it's important because sex and gender differences when it comes to diagnoses, when it comes to pathophysiology, when it comes to medications, when it comes to all aspects of healthcare, they impact women's health on every single level. And this isn't, we had this amazing talk initially talking about how this impacts women of color even more. I can't stress to you enough how much of a problem that is. We have a huge problem with Black women mortality in pregnancy. It is all over the news all of the time. Why is that? It's not because they're not advocating for themselves. Case in point, Serena Williams, if one of the most famous tennis players in the world is misdiagnosed because her symptoms are ignored, what does that say about those patients who don't have the resources that someone like a Serena Williams has? So when we're talking about this in 2023, we've come a long way, and the Revitalization Act was a key component to starting the movement towards really focusing on this. And we're starting to see in cancer, we're starting to see clinical trials and industry, pharmaceutical companies really focusing on getting diverse individuals enrolled in the trials, whether it's gender, whether it's race, whatever the demographics are. But we are a very, very long way from having the impact we need, where we are providing exceptional care to our women patients. And so we really need to be intentional in thinking about how the decisions that were made back in the 1950s, 60s, 70s, 80s, 90s, and even today are still impacting the way we are treating our women patients.
Thanks, Shika, for that perspective. You bring up a point about, the drug-specific, sex and gender-specific dosing for drugs and drug development. And I want to highlight something that the 1993 NIH Revitalization Act only pertained to human subjects research. It wasn't until 2016 that the NIH implemented a policy requiring federal investigators to consider sex as a biological variable. And so now we are tasked with looking at the influence of sex in animal and cell-based studies. But one of the things that we've since found, that even though we have this policy in place, as well as the 1993 Revitalization Act, that while data is collected by, may be collected by both sexes, we're not analyzing that data by sex. And I think one of the instances where we really saw this come to light was during the COVID-19 pandemic. Vinny, do you want to share some of your experiences that you, being, if you don't mind me putting you on the spot?
Yeah. Can you hear me? Yeah. So many of you know that I am actually not a specialist. I'm a generalist, and I just was on servicing hospitalized patients, and 80% of my time is spent doing education. And so you might be like, why am I here talking about research on gender? So a lot of my research has been on gender equity and in the health workforce sense. So we'll talk about that in a moment, but let's go into the COVID pandemic. So 2020, I was pregnant and delivered on March 30th of 2020. Imagine what you were doing in our hospital. My son will be 4 years. We will always count the days and years of the COVID pandemic by that. So it'll be 4 years ago that we had the weekend of the shelter in place. I walked myself into the hospital and checked myself in, and my husband was able to join me later. Okay, so I have my son. And, it really kind of made me more of a patient, right? So then I kind of had sort of missed a lot of the stuff of the front line, although I thought it would be over, but it was not over. By the time I came back, I was still there. So, fast forward being a frontline healthcare worker and doing a lot of that work, obviously it was amazing. The vaccine came, warp speed, it was exciting. We were all going to get the vaccine. And there was so much excitement. I remember everyone was so excited. And I was like, oh, shoot. I'm breastfeeding. Can I get this vaccine, And so I am an empowered individual, and I'm a professor, one out of 4 professors in academic medicine are women. So I was a professor, and I was research scientist, and I was like, does this data exist? So I went on this rabbit hole to be like, pregnant and breastfeeding women were excluded. So I went back to the data and I was sharing it to be like, I don't know. So, I consulted with my OBGYN doctor, and the idea was we were going to do shared decision making. So 2021, okay, I am an empowered patient and I don't know the answer to this question. And so I did a lot of research, and through a lot of research and a lot of discussion around mRNA, et cetera, I was like, okay, I'm going to do it. And I posted on Twitter that I was going to do it. And I got a lot of bizarre responses. But a Wall Street Journal reporter called me and said, we want to profile you and your son because you're going to do it. And I was like, I'm going to do it. And I'm like, God forbid, but I'm going to do it. And so what happened was a lot of people replied back to me and said, thank you, I'm going to do it too. And and what I realized is, why is it that we're doing N of 1 trial and error? I myself became an experiment that day when I got the vaccine because the studies hadn't been done. And so I realized sometimes, sure, we want to be safe, right? But is going in with no knowledge safe? For a pregnant or breastfeeding individual. And so I just want to throw that out there to say, throughout that time, I have felt that, and even since, women's health is politicized. Let's be honest, right? There are reasons why nobody studies these things, and a lot of the legislation around trying to carve out what women's health is, it bleeds over into the funding for women's health and into how women are perceived in terms of what those study questions are. And so there's a lot of other things we could talk about, but I just wanted to say those things need to be thought about, and that's why it was great to see Congresswoman Jan Schakowsky talking about this as well, because we need them to care about it as well.
I think that's really important. So thank you for sharing a bit of your personal health with us. But yeah, that was one of the things we saw where women were self-reporting on social media that they were experiencing issues post-vaccine with their menstrual cycles because that data wasn't being captured.
Yeah. Oh, and I want to add one thing. If you want to improve trust, right, more data is better. And if you look at a lot of one of the most prevalent myths around the COVID vaccine was infertility and around women's health issues because there's a void of data. So the misinformation grows because nobody knows. And so that, I would say, is also a public health issue.
And so that really brings us to a good turning point, unless you wanted to add a comment, Shika.
I was just going to say I was with her throughout all of that. And she's not exaggerating on how that experience was. We were on FaceTime talking about what was going on. But the other point I want to make really quickly is when we talk about women's health and we talk about the politicization of it, I think, you know, what the congressman said earlier about the whole aspect of partnering with community members and getting them interested in things like clinical trials before they actually need one, that is so important. I mean, Vinny and I did a lot of work during the pandemic convincing people to get vaccinated, and we didn't do it in the traditional way. We did social media, we wrote op-eds, we went to food banks, we were doing webinars with schools. So a lot of it is also the trust, and Vinny is a great example of using your own personal stories and experience to build that trust, because a lot of times when it comes to clinical trials, patients, especially those who don't necessarily trust the healthcare system for good reason, may not be interested in signing up for these types of trials. So having that grassroots kind of reaching out to communities and talking to them about the fact that women's health is politicized, talking to them about the fact that, you know, their uncle from their mom's second side might have said this doesn't necessarily mean it's fact, and creating that trusting relationship between patients and the physicians and having that voice, I think, is really important when we talk about women's health initiatives, because there is a lot of misinformation and misconceptions. And so we have to acknowledge the fact that it is politicized, and how do we make sure that we not only have the funding, but we also have the trust of our communities to move forward with this type of really important research.
I agree completely. Thank you, Shika. So I wanted to make a point that, you know, as we talk about sex and gender inclusion, this aspect that our data is not being analyzed, we're not asking the right questions. There's some data that suggests that women scientists and women physicians are more likely to analyze their data by sex and gender. Conversely, we also see that with clinical data, where we see that outcomes in patients are sometimes better based on gender concordance of the patient and their physician. So, are we comparing apples and oranges, or is there really a component of the biomedical workforce in who is asking the research questions, who is analyzing the data, and how does that link up with the NIH Revitalization Act?
So I'll start by saying that obviously your identity does play a big role in the kind of research and questions that you think of and ask. And it's not just gender. I mean, it's race, upbringing, region of the country. You know, obviously people study the diseases and health issues that they know and that are affecting their communities. And obviously along the translational science spectrum, that there's certainly more basic science that may be less affected. But I still think, you know, people, if you look at people who study sickle cell disease, a lot of them are actually African American and coming from the Black community because they saw that there. And so I do think that this is a huge issue. The one thing I want to say is that for coming from a medical school, a lot of people are like, oh great, 50% of incoming medical students are women. We're all done. Let's go, you know, hang out and say, we're done here. We're gender equity. We've reached it. Okay. You know, we can also celebrate that 25% of medical school academic health centers are led by women now. That's actually huge, okay? It was only 18% 10 years ago and 12% prior to that. So we're making progress, but at the same time, I wanna say a third of R01 grants are held by women. When you look at the K to R transition, women are more disadvantaged, and most of these studies are binary, so apologize for all of that, but women are more disadvantaged at the K to R transition than their male counterparts in these studies. Our research with Anna Vollerman and Valerie Press at University of Chicago shows women are less likely to serve on study sections, less likely to serve as chair of study section, more likely to be temporary study section members, also, women are less likely to, we know there's a huge gap in publications as well and editorial boards that's been done by other work. So these are all gatekeepers of the physician-scientist, you know, pathways, if you will. And then last, look at K awards, because that's a big currency as well. So this is the thing that I want to stress to all of you, which is 20 years ago, like from 1998 to that 10-year span, 2008, over 40% of women of K awards were held by women. That percentage has dropped to a third in the 10 years after. So we can sit on our laurels and be like, oh, things look good. But when we look at who's coming, right? Look at the junior people. They're not coming, because if they're not getting K awards, how are they going to get Rs and become editorial board members and study section chairs and then deans? And so I actually think that if there's really about a focus, we need a focused effort to really think about this. So it's great that we're celebrating, but I also want to say the data does not look good, and COVID has made it worse. So I want to pause there, because there's a lot we can talk about for solutions, but just to say everyone needs to go home and ask themselves in their institution, what am I doing to keep women in the scientific workforce?
Yeah, and so what we do with Women in Medicine, the nonprofit, is a lot of research, and we've published a lot of this data, and it's not opinion anymore. It's a fact. I mean, I could talk for 20 hours about all of the disparities that exist. I mean, we didn't even talk about the pay gap that persists and the amount of grant funding that's given to women. That is, the monetary amount is significantly less. There's so many disparities that exist. So in Nikki, what you were asking about, most of this research is being done by women. That is a fact. And again, we all have our own implicit biases. We all have our own reasons why we do certain research, right? Like, I do research that I find fascinating and interesting, and a lot of it is related to gender, because I know there are these huge disparities. I think one of the challenges is when we talk about women's health and we talk about the fact that women weren't included in trials and a lot of this data isn't being done, it's not being analyzed. Why is that? It's because that was the culture. That has been the status quo in healthcare since the beginning of healthcare, because when the healthcare systems were created, women were not in the healthcare workforce. And so men were running the show, and men didn't think about these things. My husband is a physician. There are many things I talk to him about where he's like, I didn't even think about that. When I started doing gender equity work, he actually thought that this was going to be something that I grew out of in a couple of months, because he was like, there's not enough data, and you're going to realize that this isn't really a problem. I mean, we work at the same hospital, and I've never had this problem. And I said, because you are a man. So I think that there's a culture of this in medicine where it's just assumed it's not a problem, because the majority of the people who created the systems, the majority of the people who have led the systems have been men. Now that there are more women in the medical workforce, they are realizing these are disparities, and they care about these disparities because they directly impact them. From a workforce standpoint, they affect us, and then from a patient standpoint, they affect us. Women in medicine, women physicians, have a higher rate of infertility than the rest of the population. That is medical care that directly impacts us as physicians. And so obviously more women are going to be interested in doing that research and analyzing that data. So going back to Vinny's point about how do we change this, I mean, yes, it's great that we have more than 50% of women entering the workforce, but to Nikki's point, we're not getting the data we need to make real changes, because the women are not being retained. The women are not getting the opportunities to do the research. They're not getting the grant funding. And to be perfectly honest, the grant funding isn't being given because traditionally this isn't money that should be going to women's health, because no one cared about it because they didn't know they needed to care. Going to Annabelle's point initially, which is they didn't know that women were getting heart attacks in their 60s instead of 40s, so why would you research it? You don't know what you don't know. Now that we know that there are all these disparities, now that we have women in those spaces doing this research, we need to be intentional in where that funding is going, because women are more often to be voluntold to do work that is uncompensated and unpromotable. And when you're voluntold to do something by your boss, you do it. The problem is a lot of that work is done during my best productive hours between 11 p.m. and 2 in the morning when my family is sleeping and I can get quiet work done. And that is not compensated work. I've been told more times than I can count that I'm not going to get promoted because of the work that I'm doing isn't impactful enough. I should be focusing on, precision oncology related to X, Y, and Z in this one specific disease site. That's what's going to get you promoted. Gender equity work, who cares about that? And so I think we need to reframe the conversation. We need to kind of shake up the way our healthcare systems are set up. We need to fix this system so that it becomes a standard that instead of just women analyzing this data, it should just become a start of the standard way we are analyzing data. this should be a part of the data set. When you're looking at protocols, this should be one of the check boxes that everybody needs to be looking at. It shouldn't just be women who are looking at this, because at the end of the day, we are a community, and women cannot do this alone, so we need male allies. And as Vinny mentioned earlier, I'm sorry we're speaking about this in the binary, but most data that's published is published male, woman, female, man. So we unfortunately can't talk about all of the other aspects that come along with this type of care as well, which is, when we talk about our trans patients, when we talk about, all of the other aspects of gender-related care, that's not even included in most of the data. So the biggest point, I think, is to answer your question, yes, it is very clear that the majority of this data is being analyzed by women. Is that okay? No. How do we change it? We make it the standard instead of the exception. This should be included when you're doing your research. It should just be accepted that when you are doing research, these things need to be taken into account, and it shouldn't be an afterthought, or it shouldn't be something that a woman needs to raise her hand and say, hey, did we think about this?
Thank you, Shika. So I know we're getting close on time. So I want to end us with a quote, and I'm going to start with Annabelle for her answer here. So this is a quote from First Lady Dr. Jill Biden. "Every woman I know has a story about leaving her doctor's office with more questions than answers. Not because our doctors are withholding information, but because there's just not enough research yet on how to best manage and treat common women's health conditions." So this statement was made in 2024, just this month. And then if we look back and what we heard about the language in the 1993 Revitalization Act, it was very similar. And so to that end, the White House just announced their first initiative on women's health research. And so this committee is tasked with finding out this information and providing recommendations across the federal government to address these shortcomings that we're still experiencing 30 years later after the NIH Revitalization Act. So, Annabelle, if you could make one or two recommendations to this committee, what would they be?
I would say women need to be more involved in reviewing papers. We are inundated. I mean, every day I get asked to review a paper, and I can't spend enough time doing that. It is volunteer work, but it's so important. And if more women review those papers and ask the important questions, did you look at sex differences? And don't accept that paper if they didn't. Then you become powerful. So I think that's one thing we can do.
Shika?
I totally agree with that. And I also think it's really important to have women in positions of power where they are the decision makers. So whether it's running clinical trials, we know that the number of PIs or primary investigators on clinical trials, it's more men than women. And industry actually has a huge hand in that, because they are the ones who choose who is running the clinical trial. So we need to get more women in positions of leadership so that they are the decision makers, so that they make this the standard. That's number one. And number two is we need to make sure that men are on these committees as well, because if men are not at the table listening to the challenges that are there, the change is not going to happen. They should be hearing these things so they can help impact and move things forward. But we need to get more women into these positions of leadership so they can actually drive change.
And lastly, Vinny.
So I think structurally about the NIH, and early in my career, which agency am I going to go to, right? And so it's very disease-based. And then there's the Office of Women's Health Research. And so, I did sleep research. I still do sleep research. And I was actually very excited that, my former PO, Mike Twerry, emailed me to ask me what I thought about women and sleep, But that was just random because he had seen something I had written, a gender equity article that I had written. And so what if actually every PO and every agency actually had a kind of a sort of a directive to really think about how they were going to analyze gender and sex differences in all of their studies, but also what portfolio are they going to dedicate of the money they get to women's health in that disease, so that it's not just sitting out here in this pot by itself. And so I think that would be the kind of cross collaboration that we would need. And on a side note, I did want to to Shika's point, I was very excited to see my residency classmate, Dr. Kim Rathmel, who was actually just promoted or nominated to be the head of the National Cancer Institute, and then a colleague from ABIM, Dr. Jeanette Marazzo, was actually just nominated to take over for Dr. Fauci as the head of the NIAID. So I think we are making progress and want to celebrate that, but also thinking about perhaps more structural innovation would be helpful.
Great. Well, thank you. I know we are running a little short on time, and I appreciate everybody who's joined us in person today. I would like to bring Dr. Phillips back, if possible, just on screen so we could thank her. Give us just a moment, but I think this has been a very informative afternoon, and I appreciate everybody's input. And Dr. Phillips, although she could not be with us in person today, provided tremendous expertise and insight as well. And I hope we can all have a chance to meet with her in person another time in the future. But in the meantime, please join me in thanking these panelists. Thank you for those of you who joined online. And I hope those here will join us for a networking reception to follow this event. So thank you so much, everyone, for coming. And thank you to my panelists.